Okay, well, good afternoon, everyone, and welcome to Pediatric Teaching for today. Today I wanted to talk about a really important topic, and it's a general topic that covers almost every disease you can imagine. It's a topic that's become more and more important as hospitals try to improve quality of care and patient safety. So most hospitals around the world now have programs for improving quality of care and patient safety, and the identification and the management of the deteriorating patient is a very important part of that. How to identify children before they deteriorate to the point of having a cardiac arrest or a major deterioration or needing intensive care, for example. It's a major thing that we need to teach people how to do. And the reason to talk about this is that almost all children in hospitals who die or subsequently require intensive care show some signs beforehand, some physiological or vital sign change, or signs of clinical deterioration, or some sort of behavioral change, often many hours before they arrest or they collapse. And if we can identify children before they have a bad event, then they have a much better outcome. And there are now ways and systems in which that can be done. So I want to go through them today and talk about the ways in which we can structure hospitals and services to prevent deterioration and identify it when it happens. It's sort of almost inevitable. In fact, it's so inevitable that it's almost an everyday occurrence. A child deteriorating in hospital is an everyday occurrence. We see it every day. For example, a child with meningitis who's has a deterioration in conscious state or develops a prolonged seizure, that's a deteriorating patient. A child with pneumonia who becomes more hypoxic, that's a deteriorating patient. Many different scenarios you could think of where a child comes into hospital with an illness, and because of the natural progression of that illness, often before the treatment has had a chance to work, or maybe because the treatment wasn't quite right, or it wasn't complete enough, then the child will deteriorate. And this is something we see every day in our hospitals, and we have to be good at identifying it early, and also teaching other people how to identify the deteriorating patient as early as possible. As I said, it's a daily occurrence in hospitals, and I think we're seeing it more and more because not only children come into hospital with acute illnesses now, there's more and more children that are coming into hospitals with chronic illnesses who develop acute complications. They might have, for example, some chronic neurodevelopmental problems such as cerebral palsy, and they get pneumonia and they deteriorate. And these children are often more prone to deterioration than a child who didn't have a neurodevelopmental develops pneumonia. So it's the background chronic illness or their comorbidities that make them more likely to have a deterioration. And in those patients, it's often a greater challenge to identify them early, to identify the child where their baseline is not normal. It's not quite normal. They are perhaps some of the hardest patients to identify. Or often deterioration leads to bad outcomes. So it's not just that a child will deteriorate and need, some extra support. They have a much greater risk of death or adverse outcomes. And as I said, as pediatric doctors and nurses, we need to be experts in the detection and the prevention of this deterioration. There are, as you know, the WHO has this program of hospital care for children, which we follow a lot. And there are different ways in which we can identify children deteriorating, and taking a history and doing an examination and close monitoring are the main ways. We can also detect the potentially deteriorating child at the time of triage, and we need to get good at identifying emergency rooms, whether it's a triage or whether it's in the ward. And these are the WHO emergency signs, I just want you to look at the signs on the left-hand side: obstructed breathing, severe respiratory distress, central cyanosis, signs of shock, convulsions, and severe dehydration. And if you explore those in a bit more detail, for example, what does severe respiratory distress mean? When we teach nurses and junior doctors about what severe respiratory distress is, they won't necessarily know, but it's the identification of the individual signs that go to make up severe respiratory distress that we also should be teaching. So children with severe respiratory distress will have one or more of fast breathing and chest indrawing, some sort of indrawing. You can have chest indrawing at intercostal recession or subcostal recession, or sternal retraction, or tracheal tug. Sometimes these children with severe respiratory distress have head nodding, or they grunt with every breath, or they're unable to feed. So there's a whole number of signs that you need to get good at identifying to identify the child with severe respiratory distress. You need to be able to communicate those signs. So to be able to say to your colleagues, this child has severe respiratory distress because he has severe chest indrawing and tracheal tug and grunting, that sort of thing. And the same with signs of shock. If you ask someone what the signs of shock are, you need to be able to identify what those signs are. And they're having cold hands and feet, a fast and low volume pulse, having prolonged capillary refill, a low blood pressure, oliguria, so not passing enough urine, and being lethargic. So they're all signs of shock, and children with shock will have 2 or 3 or more of those signs, that otherwise they may just have some signs of shock, but not actually be in shock. So we need to get good at identifying these signs, and we can identify them at triage, but also in our regular monitoring of patients on the wards when we do ward rounds, and nurses can get good at monitoring these signs. At triage, we take a brief history of the presenting problem, and then within about a minute, you can detect all of those signs. You can look airway for, listen for stridor, and look for obstructed breathing. In terms of breathing, you can look for cyanosis and those signs of respiratory distress, including chest indrawing and other things that I mentioned. For the circulation, it's quite easy. You can get used to feeling the child's hands and feet and feeling if they're warm or cold, if the capillary refill is prolonged or not, if the pulse volume is strong or weak. You can do all those things, and you can assess for lethargy and the level of interaction. If you do all of those things, that usually takes about a minute to do. Then you've assessed for all the WHO emergency signs. And I think when we get called to see a patient, if we are used to it, if it's second nature to us, we can just go through those signs in our own mind just to be sure that the patient does or doesn't have any emergency signs. That's a good way that we can teach people how to identify these signs. I want to talk about one case, a real case, but give 2 scenarios and illustrate why, as well as being able to identify these emergency signs, it's very helpful to have a color-coded emergency monitoring chart. And we've tried to introduce these charts on a widespread basis. Most countries have now adopted color-coded monitoring and response charts specific to pediatrics. And in the past, we just monitored people's vital signs, and that's all we monitored. And we monitored it in a way that didn't help nurses identify when a child was deteriorating. But there are ways of monitoring to strongly help people identify if a child is deteriorating. This was a girl named Joy who was 7 months old. She presented with respiratory distress, a very common presentation. She'd been unwell for 7 days with cough and a high fever, and she'd been unable to feed. When she presented, she was cyanosed. She had oxygen saturations of 82%, and that increased to 92% on oxygen. And she was started on benzoyl penicillin intravenously and admitted to the ward. But her parents even after getting to the ward, remained very worried about her high fever. It was above 39 degrees, sometimes hitting close to 40 degrees, and they were very worried about that. This was Joy's monitoring and response chart. Now, she was given antibiotics at admission, but she remained febrile and she was tachycardic and tachypneic, and that increased. And I want you to look at her monitoring and response chart. This is her breathing rate, and you can see when she started, I'll just orientate you to this. The white squares are normal, the normal range. The orange squares are that's a warning. It's things are not going so well, and the red squares, the red parts of the graph, that's the danger signs or emergency signs. A child's in the emergency range, and you can see that Joy's respiratory rate has gone up considerably in the first. This is done every hour in the first 4 or 5 hours of her admission, to the point where her respiratory rate was above 80 per minute. And then she goes along with marked tachypnea for several hours, all the way through to the next day. And then she deteriorates she's gasping and has a slow respiratory rate. At the same time, her oxygen saturation, which was 92 when she came in on oxygen, became lower and lower. And the amount of oxygen she was receiving, 1 litre, 2 litres, 4 litres, up to 6 litres, was increasing. At the same time, her heart rate, which was started in the normal range, 150, 160, went up very high to over 180. And then it went down when she deteriorated at early the afternoon of the next day. Her capillary refill was normal, less than 3 seconds when she came in, and then it became more prolonged later on. And her blood pressure was stable when she came into hospital, and then deteriorated. 80 on 50 4 hours later, but 65 on 42 4 hours later. And her blood sugar also fell as well. So you can see elements of deterioration in Joy's vital signs and general physiology, to the point that she deteriorated and had a respiratory arrest at 2 o'clock the next afternoon. Well, that's what could have happened if no one took any notice of the monitoring chart. But in this case, people did take notice of the monitoring chart, and they intervened early. And I'll just show you what really happened. I'll show the X-ray I showed you then was the X-ray that was taken at the time that this girl arrested. But actually what really happened, that X-ray was taken after her deterioration was detected. So the same thing happened. Her respiratory rate went up, and because her respiratory rate got into the red zone, there was what was called a MET. That is the registrar was alerted to come urgently to the bedside and assess the patient. And the registrar assessed the patient and realized that something wasn't going right. The respiratory rate was going up, the oxygen saturation was going down, the amount of oxygen was increasing, the heart rate was going up. All of these things were going in the wrong direction. And early, about 10 o'clock that night, she got some interventions. So at the MET call, the medical emergency team call, she received increased amounts of oxygen. She was moved to the ICU area in the ward. She had an urgent chest X-ray, and I just showed you the chest X-ray. And that showed that there was an empyema on her chest X-ray. And clearly the empyema was the reason why her fever remained very high, her heart rate was going up, her oxygen saturation was going up, going down, and her oxygen requirement was going up. All of those things are explained by the empyema that wasn't detected at the time she presented, but became more manifest some hours later. So overnight, she had 300 mils of pus drained from her chest, her left side of her chest. She just received some ketamine to insert the intercostal catheter. She had her antibiotics changed from penicillin to ceftriaxone and flucloxacillin, and she had some analgesia for the intercostal catheter and some frusemide to reduce her edema. So at the Met call, all of these things were decided and they were done in the next couple of hours. And the point was, this girl had been deteriorating, but instead of deteriorating to the point of having an arrest, she was able to have a series of interventions, not one, but a series of interventions that changed the outcome. This was the chest X-ray after the intercostal catheter was reinserted and the 400 mils, 300 mils of pus was drained. You can see that her lungs are much better aerated, and she was breathing much better after that. So she stabilized. Her respiratory rate had decreased by the morning. Her heart rate had normalized. She needed less oxygen. We found Staph aureus on her pleural fluid. She had an intercostal catheter for only 3 days. It was removed after 3 to 5 days. She needed 10 days of IV Fluclox and then another 10 days of oral flucloxacillin. She was then taking breast feeds well and was discharged after 3 weeks. So what could have ended up in a respiratory arrest ended up in the identification of a deteriorating child and a series of interventions because people identified it based on the deterioration in her vital signs using a monitoring and response chart. And that's what I wanted to convey, that the use of these charts can really help us identify patients much better. So there's two things. One is the use of charts like that. And the second one is to have a system that helps that. And it doesn't have to be a very big system. Like in some hospitals, it's a small team of people that come to the bedside. In smaller hospitals, it could be just the nurses are able to call the registrar urgently based on a deterioration of a patient into the red zone. They can call the registrar, or they can call a registrar and a senior nurse, or they can call the paediatrician, whatever it is. You just need a system whereby it's possible, and the nursing staff and if a resident or a registrar identifies a deteriorating patient, then they can call the consultant, they can call the specialist paediatrician, or they can call the staff in the ICU, or they can call another specialist anaesthetist or someone to review the patient. The point is to have a system whereby escalation of concern can occur in a timely manner. So deterioration can be detected and a plan can be put in place, and bad outcomes can be averted. So as I said, the main reason for having a MET system is to have an escalation of response. And the system you have, it can be designed for your hospital. It can be whatever your hospital wants to do, depending on how big it is and how what personnel are available and that sort of thing. But just to have a system, you have to have a medical emergency system. There's lots of data now showing that these medical emergency teams, sometimes called other things, rapid response systems, that sort of thing. It doesn't matter what you call it, it's the same thing. To identify a child who's deteriorating, to have a system of escalation and have a good response from a small team of people. And lots of evidence, lots of studies showing that this substantially lowers mortality within a hospital and improves outcomes. So I think for hospitals that don't have such a MET system, then it's a good idea to think about how you would design one for your hospital. And I think using those monitoring and response charts is a very important element. If you develop a MET system, it's important that staff have training in how to recognize the deteriorating child, like I'm talking about now. So teaching people how to assess patients properly, how to identify deterioration on a monitoring and response chart, how to identify those emergency signs. They're all things that has to go into a MET system. You also need to, sometimes there's reluctance by ward staff to escalate because they don't want to bother the registrar, they don't want to bother the paediatrician, but you need to empower people to call for assistance without worrying about being criticized or being feeling bad for doing it. It's very important that people don't ever be criticized for escalating a problem. Sometimes it won't be a big problem, and sometimes it will be a big problem, but you shouldn't criticize or you should be complimenting people for the identification of seriously ill children rather than than acting as if you're being bothered. Yeah. Anyway, we know this improves outcomes, so I'd encourage it. As I say, the key feature of any system is to have empowerment of staff, so they feel, junior medical staff, junior nurses feel that they can call their senior colleagues to get some support. As I say, there's many studies showing this improves outcomes, and most of them have been based around color-coded monitoring charts that are really simple to use. There's some scoring systems. I don't think they're much more complex, and I wouldn't recommend them. I think it's better for people to be able to read color-coded charts. So I think this type of chart that I mentioned before, this is a very good system to use, and it's pediatric orientated. So I hope you can maybe incorporate that into your hospitals. The other important thing about having identifying seriously ill children is that we need to listen to parents' concerns about their child's condition. Joy's family, this girl's family, had major concerns and voiced their concerns many times about her having a persistently high fever. And I think that's very valid. If a child has a bit of fever and that fever goes down, then they're probably improving. But if they have ongoing very high fever, then that is excuse me. Yeah. Oh. It's okay. I'm just going to. Oh yeah, sure. No problem. Yeah. Oh, right. There you go. Yeah, okay. And I'll be with the registrars at 3. Is that right? Yeah. Good. Yeah. Yeah. I'll talk to you about Uber later. I think yeah. We need to listen to parents' concerns about their child's condition. Parents are really smart in knowing what their child's baseline is like. And I think especially when we have children that are chronically ill, they don't have a normal baseline. And so if we don't know the child very well, we won't really know what their baseline is. So we should inquire with the family, what's the child like? Well, what do they like at their best? Because then you'll get a good understanding of what the child's baseline is like. That's important. As I said, we need to teach staff how to use these pediatric monitoring response charts, and we need to teach staff skills for monitoring and attending MET calls. And as I say, have a system. There's one going on now, so I might have to go soon. It's useful to have a way of analysing a situation at a MET call or on a ward round. There are methods for doing this. When we ask what the situation is, we need to be asking what's the background of the child, what's the diagnosis, is the treatment that the child's receiving sufficient? Are there some unrecognised diagnoses or problems that need treatment? Maybe some diagnosis hasn't been identified or it's been missed. And what's the nature and the cause of the child's deterioration? These are questions that we should ask to explore a bit further why a child deteriorated, and to identify what things can we change. And you saw with that case I mentioned with Joy, there was a lot of things we could change to make it better for her, to help her get better. As if we'd only changed one thing, just given her more oxygen, it wouldn't have been enough. She had to have a chest X-ray. She had to have an identification of the empyema and drainage of the empyema, a change of her antibiotics, some analgesia, etc. All of those things were important, and so we need to identify the whole the package of things that we have to change to make things better. And sometimes we also need to ask who else needs to assist. So not always can we solve all the problems ourselves, but we might identify a series of things that need to be done in a particular child who's deteriorating, that perhaps you need the surgeons to assist or the anaesthetists to assist if you can't do these things yourself. And that's okay too. The point is to identify the things that need to be done and who needs to do them and the time frame in which they need to be done to avert further deterioration. I sometimes go through this system with my registrars when they're assessing a deteriorating child. And there's many ways you can do it. One is to think about the ABC, but it continues further than that. You can think about the airway, breathing, the circulation, the child's neurology. You can think about their drugs, whether they're check the doses, what drugs are no longer needed. Think about the E for exposure or environment, their temperature, their IV cannula, the pressure areas. E for electrolytes, creatinine and urea, if you need to check those things. F for fluid balance. We see many children deteriorating because of edema or because they're still dehydrated or they're in shock. You assess those things. G for glucose. Many children deteriorate because of hypoglycemia, or so check if the child's on sufficient glucose, whether they're feeding adequately. H for signs, hematology or signs of infection or anemia. So there's a way you can think about all of these things if you go through an alphabetical list of things. So that's all I want to say today. Really just, and lastly, if you're still unsure, then never be frightened to ask for a review and reassessment by a second paediatric clinician. It's always good to have one of your colleagues review a patient and just say whether they, just whether they think we're on the right track, right? Sometimes questions remain about a diagnosis and you need to ask your colleagues, or the symptoms and signs might be atypical and you're not sure yourself, or the child might not be improving as they normally would be expected to, or maybe the parents are saying they're not sure that everything's right, that you've got all the things right. Don't be scared to ask for a second opinion from a colleague or someone who might be able to help. I think these are important. So that's all I really wanted to say today. The main thing was to try to identify the deteriorating child and have systems in place, both training and clinical systems, and to teach your staff how to use such systems. I'm going to stop talking now, and I'm happy to answer any questions that you might have. Just to say, for those who weren't there at the time, I had some surgery this week, so I'm not looking so good, but that's that's all fine. So thanks. All right, I'm going to stop talking now. If anyone's got any questions, please ask if you like.